Yeah, my guess is it's unlikely we're going to be here next week as the last. Basically, that's the last week prior to uh, us going on break. Because I'll probably record what I have to record. I'll get most of what I want done today, and I only have a little bit more muscle, and then I want to do a little bit about the brain, and that'll do that. You will probably get this material again in lecture, unless I don't know if Dr. Robbins started anything about the brain yet. No, yes, maybe, yes. It's just hard to hear you guys nodding, but I digress. All right, I have a little bit more on just, there's not a whole lot with extremity muscles, just so you can be familiar with what are the larger ones, and we'll go from there. Oh, an effort. Yeah, I'll probably just send you something. And then when we come back on the 30th, after Thanksgiving, we'll do a brain dissection. I have lots of brains. I'll talk, before we do that, I'll do cranial nerves, so you can kind of get your hands into that. And then I'll give you what information we have for the finals, like a combination of written and practical. My guess is even we're going to do it in lab, it'll probably be open book. I know, I'm being nice. Show me the money. It's just a bunch of old movie lines that I use. I have such a good time with that. My wife is convinced that you guys think I'm crazy, because she's sure of it. My wife's hysterical. Did I show you her picture? No. Oh. See, you'll see she has visual impairment because she's with me. Really? Oh, I didn't do that. Oh, it's terrible. Yeah, like these days they have like a picture that shows up on your phone. Like when you're, on my iPad it does that. And my kids' pictures predominate because there's so many of them. My grandkids, and of course his poochliness. Oh, where are you? I showed it to the other class. That's why, to my advanced students. Oh, here it is. And this is a few years ago, because my granddaughter, I think, was not quite 2 years old. So I look younger. Yeah, it's like 3 years ago. June 7th of 2019. The beautiful woman you have sitting next to me. No, not the cat. They're all the animals are boys. Let's see if it came in. Oh my God, it didn't come in yet. Oh, this is terrible. How hard would it be to send a damn thing? Oh, this is obnoxious. Having terrible. Let's try again. Oh, here it is. Yay, me. Beautiful woman you see sitting next to me. That's my granddaughter. That's not my wife. That's my wife. See? That's why I'm the luckiest person in the world. And you can be too. I'm sure it's very interesting when you always know it. And both of us were married previously to very nice people. But, it just wasn't the right person. I think you always know when it's the right person. So it isn't always, it's just, sometimes it works out differently. Uh, it's just unusual with regard to things. Like I'm very convinced that the parents of that little girl, and my grandson, have seen any number of pictures. I'm sure they're set for each other, and that's the first marriage. But they got married later. I mean, Jill is well over 30 when they got married. You know, she'd been married previously. He had not. My son Adam had not. It's interesting in that regard. All right, let's get on with the show. So I don't have a lot to tell you about these. What we're dealing with now are really the muscles that go to the lower extremity. So you start to see them a little bit here. So we have, and most of the way the groups are, and there's not a lot to do. This large muscle here, and you can just about see the names if we blow it up a little bit. This quadratus lumborum is really one of the spinal muscles posteriorly. This is called the psoas major. This is the psoas minor. This is the iliacus. Together, and you'll see the animation or the way they do it in this. They come together. They're called the iliopsoas. They're a really big muscle. It goes through that obturator foramen and inserts into the lesser trochanter. So when you're climbing the stairs and lifting your leg up, that's a big player. This is the longest muscle in your body, the sartorius, anterior superior spine. So it's in front of the hip. It flexes the hip up. It goes behind your knee, so it flexes your knee backward. So it works over both muscles. It's probably at least a foot or more long, and the individual fibers are quite long. It's like a multiple tendon, and then this mass here. This is the quadriceps femoris, the big muscle on the anterior thigh. And it has four muscles. That's quadriceps means four heads. Rectus femoris, vastus lateralis, vastus medialis on this side, and there's even one underneath it. And they all come together and form a common tendon called the quadriceps tendon that the patella forms in it and inserts into the tibial tuberosity by way of the patellar ligament. That's the knee jerk area that's there. So, these are the adductor muscles, the medial muscles of the thigh, which you hear in sport, they'll say someone pulled a groin muscle. Those are the, quote, groin muscles. Because they're mostly inserted on medial thigh, and you can feel pain anywhere along in here, even deep into the inguinal or groin area that's there. And and these are all, the big thing about lower extremity, big muscles. Okay? So just take a look, and that's really a pretty good schematic or animation. Iliacus, psoas major, lesser trochanter that's there. There's the really long sartorius muscle that's there. And if you see somebody with Olympics or swimming, any of those, and you can see the muscle definition on those athletes so very, very well. And I always found that fascinating. There's a whole slew of muscles that make up these adductors that rotate the thigh medially. Gracilis, an anatomist, was a graceful looking muscle, not delicate, but for whatever reason in their eyes, attractive. So they called it gracilis. So there's a whole group of these that are here. And that opening is so pivotal. That's in the very broad adductor magnus. And that's where, as you will come to see next term, the femoral artery goes through that and goes from the front of your leg, front of your thigh, to the back of your leg, behind your knee and the back of your leg. So there's not a whole lot of major arteries that go from front to back. This one does. And all the information that's about it. Here's that, so we call it the adductor hiatus. So you have the magnus, which is large, the longest, the short, which is brevis, pectineus, which is really a pretty sturdy muscle. So all of these get affected by that. And here's the quadriceps, the all quadriceps tendon. Very powerful thing. If you're kicking a ball, a football player kicking off, that type of thing, a punter, powerful muscle. And they're named vastus because they're so big, they're vast. The vastus lateralis over here, there's certain muscles that you, particularly in nursing, would be familiar with. Deltoid, because you give intramuscular injections, they're thick. Deltoid muscle here, very easy access. On the thigh, vastus lateralis, and in the hip, it's gluteus medius. Not the maximus on really your butt. It's more on the hip. Because again, the butt, that gluteus maximus covers the sciatic nerve. You want to stay away from that. You don't want to hurt the nerve. So and you'll learn about palpating these, using your fingers to make triangles and things like that. Yeah, it's not my area of expertise, but it's very interesting. So here you can see them. Here underneath, we've taken the rectus femoris away. Vastus lateralis, very big muscle on the thigh. And I mean, I've utilized these even for myself when I would have to give myself an injection. So every so often, before I was on a different medicine, I had to inject steroids for my arthritis. And that would be an easy access point. That's there. So you can see the size, dramatic. Rectus femoris here, vastus lateralis, it's vast. And underneath it, there's one, and that's the reason we use that. We use this, it's called the vastus intermedius. It inserts into the capsule of the knee, so it's used for knee strengthening exercises in rehab. Work with me here. And they're showing them to you. The tensor fascia lata. The fascia is the connective tissue that binds those muscles to the thigh. Powerful. The fascia lata is here. So it's like an anchoring point. This tenses it. So it helps to hold those muscles in certain activities. These are all things we see injuries to in sport, and particularly you're more prone to problems as you get older. It's easier to, I mean, even it happened to my wife the other day. We're raking leaves. The leaves were a little bit wet. Boom, she went down. It doesn't take much, and this is one of the things you become a little as you get older, and this is something to coach patients for, since you guys are not about being very watchful about those types of things, where you step, what you do. Here are the gluteal muscles. Now, these are more along the back. They're extensors. So they're really the way that allows you to stand up. The maximus also laterally rotates, medius and minimus. And there's these others that are really more probably supportive muscles. So it's this large mass. The maximus covers it, and the other ones are underneath it. So here you can see it. Here's the medius coming from the exterior of the iliac. That's why I want you to know about iliac crest, because when you feel that, and you know you're there, where the sciatic is over here. And then this covers over, very famously, the massive muscles in the back of your leg, which are your hamstrings. So the name comes, and the strings, because the tendons you can feel, and the ham is because that's where we make ham from, the back of a pork thigh. Why the Jewish guy knows this, I don't know. So, there's a whole other routine that I do that I'll spare you of. So on the exterior portion, it's got a two-headed muscle called the biceps femoris that inserts, and this whole area is the popliteal fossa. On the medial aspect, you have two separate muscles. One, it's part muscle, part tendon. They call it semitendinosus. And one here, that's the most medial, called semimembranosus, because if you lift that muscle out, it's got like a membranous interior. So it got those names that are there. And having dissected them from a cadaver, I can tell you it's exactly what, and they're huge. And then you have sort of an opening here and deep within, that's the popliteal fossa, where blood vessels and nerves and vital structures traverse. And these are the start of your big calf muscles, the medial, this is the medial head and the lateral head of the gastrocnemius. So you can see them here a little bit in this actual dissected specimen. The maximus, now you can see at least part of the hamstring. Here's part of the semitendinosus. And then we work our way over to semimembranosus. It's there. So they're just showing it to you. So these are just useful to remember. If you cut away the maximus and the medius, then you can see all these deeper muscles. So there's a lot of, and that's what I mean, the hip is very, very well secured, not just by the architecture of the joint, but by all the muscles and tendons. It's held in there a lot. Okay, so across the hamstrings, across both joints, so they flex, they extend the hip and flex the knee. It's almost like you're bringing your leg back. So they're prime movers for thigh extension, knee flexion, sciatic innervation. Very, very common, ultra common sports injury. Has ended a lot of great, a Hall of Famer for the Steelers back in during the 4 Super Bowl years, ran for governor of this state not so many years ago. Lynn Swann, one of the great athletes of all time, was a national champion in the long jump and track, and then came to the Steelers as a wide receiver out of USC. had a career that maybe lasted 8 years at the most, injured. He would pull his hamstring and be done. So the years when he wasn't injured, they basically were winning a Super Bowl, except for maybe the last one. Just to give you an idea, and you saw those illustrations. Here's the biceps. So you have ischial tuberosity, you have additional attachment to the femur, and down here, sort of below the lateral condyle of the tibia, where you'll see semitendinosus. Now this insertion is more medial, the biceps is more lateral, and then the semimembranosus. And they're so large. And then other than that, there's not a whole lot of other muscles to contend with for your purposes for the time being. And they're held together. What happens is the leg is a bit different than the thigh. Thigh has the fascia lata. This has what's called crural fascia, but it's compartments. And a very important problem in sport is called compartment syndrome. And it has more to do with foot and leg position during a sport. But the muscles have, if it swells, they're held in these compartments. They have nowhere to go. And it can really cause significant damage. It can cause the muscles really to degenerate and not be repairable. So there's a lot of materials that kind of hold things in place. And I'll show them to you in a bit. So you have your shin. If you move a little bit to the outside laterally, you have the anterior compartment. These basically help you bring your toes towards your nose. Okay, that compartment. They have different muscles. Tibialis anterior extends the digits, extends the big toe. The tertius, which is variable, that's there, and they're all along this side. Here they are. Here's the shin, basically the exposed subcutaneous portion of the tibia. These are posterior muscles back here that we'll get to on sort of there's two posterior compartments. But these are quite large. These are usually the ones that are affected by, and you have another disease that you hear athletes get called shin splints. And what they do is it has to, again, do with foot and leg position as your body's trying to stabilize it when you're doing running or walking or doing different kinds of activities. Little bits of the muscle pull away from the shin bone, which they're attached to, and make it sore. So here's tibialis anterior, one of that group that helps you bring up your toe. Gluteus longus, extensor digitorum. One goes to the toe, one goes to all the lesser toes. They just show you the pictures for it. The lateral compartment has two stabilizing muscles that run behind the lateral malleolus. They used to be called peroneus, now we call them fibularis, longus, and brevis. And one of them inserts into the base of the fifth metatarsal, and frequently that's a piece of bone that gets chunked off in sport. And the other one goes as like a super stabilizer that starts here and ends up all the way going across sort of the bottom of one of the arches. And so those are muscles that are commonly injured as well. You can see that long course of the fibularis longus goes all the way to the base of the first metatarsal plantarly. On the other side, here's the brevis into the tuberosity of the fifth metatarsal. And other than that, we have the big mass that ends in the Achilles tendon, the medial and lateral heads of the gastrocnemius, both enormous, becomes very much tendon, and then deep to it is an enormous wide muscle that's the stabilizer, the soleus, and the fibers, and tendon fibers join together, spiraling, insert into the calcaneal tuberosity and the very famous Achilles tendon. So it's either tendocalcaneus or tendoachilles. Here's the cutaway from the gastrocnemius, the solea. It's an immense muscle. So there you can see the gastrocnemius, and then deep to it, the soleus. You have to take my word for it. When you dissect that thing, it's a monster. And really, I think it's about all for us. There's some other interesting nuances. If you go into a field where you do a lot of orthopedics and the different layers, the bottom of the foot's got 18 or 20 muscles. The top has one. So it's quite a bit different. There's not a lot on the top or dorsum of the foot. Bottom of the foot, a lot. And a lot of those are analogous to, and this is something you learn. This cross-sectional anatomy is something people in the imaging and we're doing it again. My colleague and I are doing what's called radiation biology for some of the folks who are in the nursing area, they have those that do imaging, that type of, they're involved in that kind of science, and it really is very interesting. They do it. Their degrees in nuclear medicine. That's also a very, very good field. So they take a lot of the same courses you do. So they've got my colleague and I are splitting a course, doing it again this year. Go figure. More work. So that took 20 minutes or so, and included pictures of the kitty. What else could be better? Kitties. Which brings us to this guy. And I'll give you I'm going to give you my schematic, how it works. I've been doing this for the better part of 25 years. It's not magic that I developed. A lot of people basically approach it similarly. The central nervous system is the brain and the spinal cord. I will present to you probably separately the spinal cord, because there's not a lot to say with it. We have models and things here, and I don't ask a lot of questions about it per se. You probably get to revisit it again in AP2. So the whole idea of the brain, okay, and this concept of cephalization, okay, is the development, tremendous amounts of nerve cells, neurons. And if you compare, we're going to dissect the sheep brain, it's not nearly as elaborate, certainly nowhere near as big, but you can tell by what are called the convolutions. It's not as high. If not, the sheep would be teaching, and we'd be dissecting, they'd be dissecting us, right? You know, that. They'd be talking in sheep. Bah, 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 bah. It's an old joke. Remember when one shepherd said to the other, let's get the flock out of here. It's a sheep joke. Oh. I thought that was clever. I know. My grandpa told me that joke years ago. Don't start. Your grandfather probably told you that joke. If he had it, he'd have told it to you. Grandpa's crazy. So you have in it, there's a couple of things that carry on from embryological life. You saw one, the notochord. That became that nucleus pulposus that we talked about in bones in the spine. You're going to learn about the eustachian or auditory tubes. Those are pharyngeal pouches. The other thing that vertebrates have is a neural tube. That tube, hollow in the center, thick along the sides, a la a bone, a long bone, certainly not nearly as rigid, is really what becomes your central nervous system. It forms these different structures, which are called vesicles. You don't have to know. The only name of these that sticks around for your purposes is this, the midbrain, because it's the same name as during development. Encephalon means having to do with the brain. And so these are terms that were hindbrain was rhomben, midbrain, meso for mid, procen for fore, and again, my Latin's very rusty. So what happens is these divide, the fore and the hind, the midbrain stayed the same. So these are not names you have to recall. What it does mean is that you will see that this hollow tube thickens, expands, twists, folds over continuously on itself in a recurring pattern and forms what you and I call the brain. So what you're going to see, the cerebrum, which is the highest order functioning area of your brain, and by far and away the largest, 85%. The diencephalon, less. Between the diencephalon, which is highlighted by visual activity by way of the retina, as well as the collections relaying signals to the thalamus, the hypothalamus sensing and controlling environment and being a go-between to the endocrine system, and the epithalamus unclear. The midbrain, relatively small, pivotal role in making chemicals that we're talking about, at least I am in lecture, called neurotransmitters. The pons and medulla oblongata, really, along with the midbrain, part of the brainstem, and a very unique area called the cerebellum, which coordinates all of our muscle activity. and to some extent records that information. So and that occupies about 10% of what we call our brain. So between the cerebral lobes and the cerebellum, 95% of your brain. So the rest of these are sort of like areas and passageways that have some functionality. And what we see highlighted is a tube, and that tube is filled with fluid we call cerebrospinal fluid. And not only is it inside of these structures, it has little areas where it comes out and surrounds it. So your brain and spinal cord have fluid in the middle for buoyancy and are surrounded by the fluid for protection. Because you couldn't jump up and down without your brain striking something if you didn't have inherently this buoyancy. And people with damage to that leak spinal fluid, it's almost as though their brain collapses in, sort of buries itself or falls into the foramen magnum in something called, it's almost like spinal fluid hypotension. Arguably, my wife's best friend has that from a back injury at work and subsequent trying to treat it. Life changer. Here's the tube. So blue filled with fluid, outside what we kind of gray matter, basically nerve cells coming together. Look what happens over time. It expands, changes shape, outpouchings. These are going to become your retina going to the eyes. This is sort of like the optic chiasm. And when we begin to see these little changes in color on the exterior, these are extensive development of high order functioning gray matter. This becomes the cerebellum. This becomes what are called the cerebral cortex, plural being cortices. That's what hopefully you're all using right now, because that's problem solving, memory, processing, listening to the sound of my voice, deciding what's important or unimportant, all of that. And all of these fluid-filled areas collectively are called ventricles, though they have some names, and we will have to go over all those. So the brain goes faster than the skull itself. So even though the skull is growing, it's only enlarging a little from a baby to you and I as an adult. Just look at baby pictures and look at your own pictures now. Your head hasn't expanded. Your brain has grown very fast. So it folds. Okay. The forebrain moves toward the brain stem, and you'll see some of the illustrations. The hemispheres double back, enveloping the area. And so you'll see the transition between the week 5 brain, when a lot of people don't even know they're pregnant. Okay. And we're talking about something that's, barely measurable, where you have, just some little bit of changes. The start of a spinal cord, this neural tube, widening a little bit here, a little bit here, a little bit here. By week 13, the end of the first trimester, you have effectively the development of the cerebral hemispheres. You have the start of the retinas. You have the start of the thalamus, the midbrain, the cerebellum, what's called the pons and the medulla, and the spinal cord. That's very reminiscent of the brain at birth, which you're going to see shortly. I'll show it to you here. Not a whole lot different. But yet now you see convolutions. You see a well-developed, what's called the diencephalon, the thalamus, the hypothalamus. You can't really see the epithalamus. That's the brain stem itself depicted here in the green color. And then this sort of brownish area here, that's the cerebellum. Again, exclusive of this area, this and this, the green and the purple, that's about, of the volume of the brain, about 85 to 90%, arguably, maybe more. So the adult brain, which is our area of interest for now, cerebral hemispheres, and outlying them is the cortex. You're going to see a recurrent pattern, and the pattern is always the same. If I had a marker, I would draw. Why you go? Maybe it's in my mind. No, all right. I won't draw it. I'll find something to show it to you. And the pattern is fluid on the inside, white matter, and then fluid on the inside, some gray matter around it, then white matter, then more gray matter. When you have those areas, that's the highest part of development. And we'll catch it in the slides, perhaps not today. So we're going to look at these areas, the cerebral hemispheres or lobes, including the cortices, the diencephalon, which has the thalamus, hypothalamus, epithalamus, and a very interesting area filled with gray matter called the limbic system. That's really your emotional center. The brain stem, by definition, the midbrain pons, the medulla oblongata, and that interesting area behind it, kind of getting patterns of muscular activity called the cerebellum. And there's that what I showed you before at birth. So what we see are areas of gray matter, which are connections called synapses, non-myelinated fibers, because myelin is white, and lots and lots of nerve cells and supporting cells. The white matter are large bundles of what we call tracts, TRACTS, which are really the conduits or passageways for nerves communicating with one another, sending messages forwards, backwards, up, down, side to side. The basic pattern, which I was going to draw if I hadn't taken my marker out of my pocket, has a central cavity with fluid, cerebrospinal fluid, immediately surrounded by gray matter, then white matter external to it. Only in areas of the highest functioning do we see additional gray matter exterior. The spinal cord has that pattern. You'll see it. As we get higher into functioning of the brain, we see those additional areas. So this is better than me drawing it. When we get to the spinal cord, it has this sort of butterfly kind of appearance. Central, a little bit of fluid in the middle, gray matter that projects in different, and an abundance of white matter. So you have this general picture all throughout the spinal cord, subtle differences. Say, the brain stem, there's some additional gray matter scattered, more function. The cerebrum and cerebellum have the outer gray matter, much thinner than you think, called cortex. So you'll see that. For instance, this is in the brain stem. You have a larger cavity. You have lots and lots of these islands of gray matter. This is the medulla. Okay, big player. All of those islands control things you can't control. They control breathing, heart rate, digestive processes, kidneys, lungs, stuff like that. What we call autonomic functions. And now we get up into the highest functioning areas, and notice the way these change. How do you know where you are? You look at the cross section. That's where cross-sectional anatomy. These are ventricles. This is a ventricle. This is an indentation, a very large sulcus. Okay, those all tell you where you are. If we were a little farther up, we'd have a couple of big units here and here called eyeballs. So you kind of can see in your mind's eye where these sort of slices are moving. That's a real gift for people who do these imaging courses that, for instance, there's another division from, your nursing division. Okay, when they begin to look at these things, cross-sectional anatomy plays a role. Doctors think about that a lot. Radiologists think about it a lot. It's a gift to be able to sort of, I'm here, I'm here, I'm here. It's kind of what we do on MRIs and CT scans. Basically able to see structures cross-sectionally. So it's fascinating. So you have a little area of gray matter external, all the way around. Islands of gray matter internal. Fluid here, an abundance of white matter. So we see all of that. And I'm not going to do this now in the interest of time. I want to give you my sort of concept map, which I need a marker for, of course. Yep. I'll get one. Don't look at me like that. I'll find one. And so the ventricles themselves, without going into all that, what eventually those hollow tubes with all the twists, enlargements, folding, have created this intricacy of shapes that you will actually see. You'll be able to identify many of these areas, the lateral ventricles, giant C shape. Third ventricle, sort of a big cavity in the center. The fourth ventricle, kind of wide between the cerebellum and the brainstem, and even the central canal, all the way down. Let me see if I can find a marker in my travels. Yeah, I make a mistake every so often grabbing a Sharpie. If I use this, I'd be in big trouble. On the recording, sorry for the delay. I was busy. Too old. When I retire, we're going to get a house that doesn't have steps. Right now, we got steps. I don't like it. It's sort of like a series of areas. You have the cerebral area, particularly the cortices, the gray matter on the outside. Okay, you work your way down to that, something called the basal nuclei. Farther down, you get to this thing called the diencephalon. As you work your way down, you get less and less conscious control, some degree of mostly subconscious control, and then eventually no control whatsoever. You get midbrain, pons, medulla, finally all the way down here, spinal cord. There's no consciousness, there's no high order functioning at all. The spinal cord more or less is lack of better word. Not a lot going on. Organizationally, there's 5 lobes, 4 are important for us. And the cerebral one's very primitive. Frontal, parietal. Notice the names are very similar to bones in your place. Temporal, occipital. Because when you learn these names, you get muscles, lobes, arteries, nerves, all that kind of stuff. There's another area that's sort of on the interior that's very primitive, called the insula. Primitive taste and smell, those are older things. When you think, dog, whenever I go and make something, just imagine I look at the kitchen. So, you're making toast, I like it. Really? He doesn't say that, he can sort of like, he's like, I'm sitting down with the heads in my lap. His nose, but his nose. Google nose, big nose. So those are those. We'll get to them, what they do in a second. The basal nuclei have to do with some amount of motor control. The The diencephalon has four components, dominated by something called the thalamus. You have the hypo, which means below it, thalamus. The epithalamus, which means above it, outside of it. This sort of interesting area called the limbic system. The limbic system is a series of portions of lobe tier and other structures that are associated that play a pivotal role in how emotions vary positive, whether it's love, hate, disdain, anger, those kinds of things. To some extent, we control them with our consciousness from the cerebral cortex. Sometimes they take over. So you think of somebody with anger management issues, okay, that's where those controls are not able to deal with. We see a lot of that. A lot of that goes on. There's a whole lot of intricacy about understanding this. So some of it's, and for instance, there's an area in the limbic system, the area that controls anger is called the amygdala. So when we see that lighting up excessively on scans, very often those people have anger issues. There's another area we now see with scans that is less, in that same system, that's less active. It's called the hippocampus. That's very characteristic of memory loss, so we see it a lot with Alzheimer's. Years ago, we couldn't diagnose Alzheimer's other than postmortem. So you have to take a section of the brain with a microscope with characteristic changes in nerve cells. Now we can use scanning techniques and functional MRIs, PET scans, which look for different areas. We have some images of that in this PowerPoint. We won't use them today. The midbrain makes neurotransmitters. I'll amplify this a little bit more. More than that, and it plays a role with regard to important reflexes. Pons and medulla are very, there's not a whole lot going on. That's where you're going to see mostly autonomic function. We have absolutely there's no significant things that are controllable per se, or really it's a relay center for signals going up and down. There's nuclei, which are gray matter for cranial nerves. Again, circulation, breathing, heart rate, gastrointestinal, kidney function, that kind of stuff. Stuff that we really don't control. How do we control it? We're trying to deal with it with medications that can impact those systems. And lastly, the spinal cord, which is nothing really more than a relay center. There's no extra islands of gray matter to increase function whatsoever. Behind this area, particularly the pons, like extending from the midbrain to the pons, is this other very interesting area called the cerebellum. It's kind of like a center with a fair amount of gray matter and has cortex externally. And what it does is every time you do something, like, I don't know about you, but when you're leaving class, you tell yourself, well, I better stand up, I better get my stuff, I better turn to the door, right foot, left foot, and this one. You do that, I don't. So like, it's automatic pilot, isn't it? I'm going to go to my car. I know where my car is, I walk over to it. Okay. Those are all programmed. You have a memory for these things. The cerebellum it's got a very fancy term. It's an interesting name to remember. It's called ipsilateral. It means on the same side, motor, which means movement, coordination. So very active, me writing on the board. I know I had to lift my arm up, but I had to. On this side, I had to adapt certain muscles to one movement. Move this, stabilize this. It remembers all those activities. And in doing so, it stores that. So to a certain extent, there's muscle memory that's going on there. It's constantly receiving signals, okay, from very interesting nerve sensors that you have called proprioceptors. Proprioceptors, I mean, do this experiment right now. Close your eyes and tell me where your hands are. I'll bet all of you can do that. My hands are on the table. Your hands will be folded in front of you. You may have one on yourself on one under your chin. You knew that. Closing your eyes. Didn't you? See? That's because your proprioceptors work. They tell you where your body is in place, in time, and space. I know that I'm standing up. I just know that. I know my hands are. No, I'm smart. You're laughing. So your cerebellum is able to get all that information, and in doing so, tell you how to move your body. When your cerebellum in the fancy word is obtunded, but it ain't working right, say in my old neighborhood, you have problems. This is a very famous problem. Do what I just did. If somebody with their cerebellum isn't working right, and they close their eyes, they can't read that information from their proprioceptors. What someone might do, say with diabetes and peripheral neuropathy, which affects the proprioceptors, they will literally walk and watch where they put their feet so they don't fall over. You need to have two of those three things: your eyes, your cerebellum, and these sensors, your body. You take it. As long as you have two, you can get around, whether you're steering or you're walking. Okay? Or, like you and I close my eyes and I can walk. I know where I'm going because I can feel with my feet, right? You take two of those three things away, happen. None of you, I assume, have had this happen to you or they will, sometimes a police officer will stop you because of erratic driving and have you close your eyes and walk a straight line, or close your eyes and put your finger. Drunk test. Okay? It measures whether your cerebellum is functioning. If it's obtunded by alcohol, you in nursing or future in that area, for many of you, you don't want to have that problem. That is a drug-related offense. Not good for somebody who's with gas medicine. Controlled substances. Take this to heart. I had the same discussion with my son on scholarship, full scholarship if you came to get into the Navy. The lecture, the father would give his child, don't F up! That's why he moved, so he could be crawling distance from his local club. Jack's on his house. Back at my daughter, after recently, her fiance bought a bar on the south side of the This is what I have to put up as a parent. Cerebellum. That particular sign is called Romberg's sign. That's a really interesting sign. So that's the foundation of the field sobriety test. It's the idea that the alcohol affects your cerebellum. You can't coordinate that information, take away your eyes, and all of a sudden people are falling down laughing because they can't. So, okay. Cerebral cortex, frontal lobe, highest order functioning. Everything, thinking, forming an answer, language, all of that comes from that. Motor activity. Anything that you're moving or causing a reaction in your body or gland is from the frontal lobe. Parietal sensation. If you feel something, it's there. If I know I'm touching this, it's going to a specific area that you will see not today in the frontal lobe. Okay. Temporal lobe, hearing, balance, also. So it kind of works in concert with that cerebellum aspect. But balance is more about position, head position. Hearing, self-explanatory. Occipital visual process. Easily more than half of your nerve circuits are traveling to the occipital lobe for one purpose, to process visual information. We are very visually oriented. Most of us are visual learners. Some are auditory learners, but vision is a big dedication of what we have. motor control isn't just our brain in the frontal lobe saying, move this, how fast we move it, how slowly, in what direction. Do we do it easily? Have to hesitate? Do we not? There's all sort of the fine motor control. So a lot of that, those fine points within the motor control come from islands of gray matter that are deep inside the cerebral area. Those are the areas that, when there's damage, are associated with Parkinson's. There's a passageway from neurotransmitters being produced in the midbrain that go to those areas that's very often the one that's associated with classic Parkinson's. Parkinson's disorder. People walk either very slowly, very agitated. There's a whole area on this. We'll kind of get to it. But a lot of times we supplement people by giving them a medicine that will cross the blood-brain barrier, that will make more of the neurotransmitters. The one that we're talking about is called dopamine. It's one of the neurotransmitters we learned about in lecture. Give them a precursor substance, and it's historically been used to treat Parkinson's. The diencephalon, the thalamus, more than anything else, is a relay center. It's not enough for me to feel something, it's got to go to the right part of the brain. Okay, so if I'm feeling something with my finger, what part of the brain is going to? The thalamus has a whole set of white matter that causes those impulses to be directed. Whether you're hearing something, seeing something, feeling something, smelling something, the thalamus says go here, go there, go there. So it directs the impulses. It's really important. It's the largest part of the diencephalon. The hypothalamus is the relay, the connection to your endocrine system. So we call it the neural endocrine link. So when something affects you, sometimes things just affect you. You'll see something, oh, I'll do this, I'll do that. Car comes. Somebody crossing the street, you'll hit the brakes. Okay. It's just so rapid. I don't know about you, but if you got close to an accident and you walked into the room and you just got out of your car, you would be able to tell if you did somebody you knew. What happened? Well, look at yourself. You'd be breathing heavily, expiring, your face would be flushed. You would sort of like, trying to catch your breath, right? Someone who's more than just an acquaintance, you would know what they would look like. That's what happens when there's that kind of a response. Your endocrine system produces longer things for you. It's your heart rate, your respiration, elevates your blood pressure. Those are the kinds of things that will linger, not for the seconds of your nervous system, but for the minutes and even hours. Most of us calm down in a few minutes. That's what goes on. That's where the hypothalamus communicates that to the central gland in that area, the pituitary. That pituitary gland can basically shuttle things all the way. The epithalamus, not sure. We know it's responsible for body rhythms. And so body rhythms are wake-sleep patterns, things that we do. Chemicals are released at certain times of day in our bodies. So, and it will change. For me, if you guys are going to nursing, some of you are going to be light people, some of you are 11, some of you will be 11 to 7. Some of you work 12 hours, 7 to 7, be to 8 p.m. They're all available to you. Everybody kind of, I'm a daylight person. I get up early, I go to bed relatively early. My best functioning time is an hour. My wife's 3 to 11, all day long. She'll be up at night, I'm going to turn off the bed. I don't want to, okay, dear, I got you. See, again, I know how to handle it. So that's what you get. The midbrain neurotransmitters is also have an area that's responsible when you hear something moving your head, you see something out in front of your eye, and reflex. The pons and medulla, not a whole lot to talk about. The spinal cord, again, not a whole lot to talk about for now. Mostly anatomy. I hope that in lecture you'll deal with it. I know I shall. with more of the functionality and the nuances about. That's why I don't have to do a lot of it today. We're here. So that's my sort of concept map of what goes on in the brain. And for those in lecture, I'll probably do this all over again. This is what I do. Okay, but I thought it's a good idea now. What I'll do is I'll pick out the important parts of this section in absence of our not being here next week to give you this information. And then I'll do cranial nerves, which you might end up doing again in AP2, but I think they're important if we're going to do a brain dissection. So I want to give you all the stuff necessary now to do the brain dissection. That is all. Thank you very much. Be on your way.